Dr. Howard Rollins with EHR TV, and I have with me today Dr. Eric Fishman with EHR TV and the esteemed Dr. Elizabeth Frost, a professor at Mount Sinai School of Medicine. Dr. Frost, we are very proud to be in your presence, and we know you have a lot of wonderful stories to tell, and you've had an amazing career in anesthesiology. Tell us the most interesting thing that's ever happened to you in this field.
Well, there's been a lot of interesting things, and first of all, it's nice to say that you're happy to be with me. I'd like my sons to hear that for a start. They could never imagine why anybody wanted to ever hear anything from me. And when I said to them once that not only do people get up early in the morning to listen to me talk, they sometimes even pay for it, and they were certain that was absolutely nonsense. Well, I don't know what's really happened that's been standing out as being more exciting and more wonderful than anything else. Many things. The residents that I've been involved with, the teaching I've done, being admitted to the Association of University Anesthesiologists, becoming a professor in anesthesia at a time when there were very few, if any, women in the United States who were given that honor. All of this has been very exciting and has been building on many things throughout my career.
I asked you earlier, who do you think the most famous anesthesiologist is? And I know there are many, but let's talk about that a little.
From a female point of view, I'd say that probably Virginia Apgar. I met Virginia Apgar a very long time ago. I actually had come to this country because I had applied for a job in the United Kingdom right after I had graduated. My credentials were much better, as I saw it, than the other man who was applying for the position in London, a house officer job. But of course he was given the position because, as the board explained to me, you understand that we have to keep everything just the way it is, to which I'm looking at a whole room full of men. I said, I don't understand, explain it to me, to which they said, well, the trouble is, you see, you don't understand. With that, I left the country and came to the United States because I found a hospital in New Jersey that was prepared to pay my passage if I was in the top 10% of my graduating class. So I came to Englewood, New Jersey, and this is a bit of a long explanation, but that's where I met Virginia Apgar. She was part of a quartet that she played the cello. And I would go on once a week with Dr. Driggs, who was an internist, who was my mentor at Englewood Hospital. And I met with her and actually played the piano with her sometimes. And she told me about anesthesia and how great it was to do that. Now, at that point, I realized that the public expects a doctor to do two things: to deliver a baby, take away the pain. Well, I was already a diplomat of the Royal College of Obstetricians in London. I was already an obstetrician. I didn't like it. And then I decided, what else is there to do in medicine? I better become an anesthesiologist. So after I had got through my time in Englewood, I went to New York Hospital and became an anesthesiologist and never forgot the wonderful times I'd had with Virginia Apgar.
That is a fantastic story. It really is. Dr. Fishman?
And so continuing along with New York, I understand we both spent some time at Albert Einstein, you possibly a bit more than I did. And if you could tell us some stories about Albert Einstein College of Medicine, I would love that.
Oh yes, I was at Einstein for a long time, and for many years I was in charge actually of the medical student teaching. I would have them for a week or 2 weeks. They'd come to the Department of Anesthesia. Well, we had a great time because at that time things were a little different from right now. So I would have them all breathing nitrous oxide, and then they would draw things on each other's arms. And I remember one medical student drew on somebody else's arm under the influence of anesthesia. He put a heart shape and put arrows through it and put somebody else's initials and not the initials of that medical student's wife. So that was a little bit difficult. But we had a lot of fun with the medical students. In fact, I remember one group of medical students actually took me out to lunch because they thought I was the coolest teacher that they had because I gave them the drugs too. When I was at Einstein, starting out at Einstein, I was very interested in neuroanesthesia right away. We were still getting out of the age of having drugs that actually blew up, like ether and cyclopropane. And the surgeons wanted to use cautery. Now, that's not a good idea. So you had to sort of put a lot of wet blankets around everything. I remember one interesting time, too, when a resident in neurosurgery, he was using a whole air drill to drill a hole in somebody's skull. Now, I'm sure as you remember that time, we re-sterilized everything. And the whole air drill, all that rubber around it was all gummy and sticky. So as he applied the pressure on the drill, he wasn't getting much air out because behind him, the rubber was blowing up and it exploded with an enormous bang, into which the poor guy fell down on the floor and screamed, "I've been shot." Remember, this was in the day of the mafia and everything else at Einstein. And we have a lot of fun at Jacobi, like the time when somebody had been shot but not quite killed. I was in the recovery room at Jacobi, and the mafia guys came up to finish it off. So they came to the door of the recovery room, and I just said, "That's it, everybody out of here, you can have your patient." Or the other time when somebody had, I was with, I don't know if you remember Dr. Thaler, he was an ENT surgeon, and this patient had come in with every bone in his face was broken, and there was a lot of his thugs along with him. And Thaler had said something to the effect, "We may have to do a tracheotomy," to which these thugs got Thaler by his shirt collar and pushed him up against the wall, and they said, "You cut his throat and we cut yours." And Thaler looked at me and said, "If you never got an endotracheal tube in before, make sure you get this one in." I said, "Whoops." So I called down to security, and I said, "Can you come up and help us?" We were in Van Etten. And they said, "Are you kidding? Those guys have got real guns. We're not coming." So that was Jacobi, yes. Jacobi and Van Etten. And then I was there, of course, when Einstein opened. And that had its problems, too. I was in the elevator one night, and this woman got on the elevator, and she came up, and I had my mask around my neck. She began to twist it, just staring at me. And I thought she was going to choke me, so I turned around quickly, kicked her right against the wall, and got out of the elevator. And the guard said, "Oh, that's Betsy. She does that every night. Don't worry about it." So it was fun.
On a more serious note, I think we can all agree that medical care in this country is in a transition phase. What do you see happening, especially in our specialty of anesthesiology and medical care in general?
It's a very difficult time. I would like to see a higher rise in anesthesia assistants. I'd really like to see us work in a more collaborative fashion with the CRNAs rather than the rather adversarial situation we have right now. I mean, I lectured at the CRNA conference this year, well received, and I had a very good time. We have a lot of CRNAs with us, and we enjoy working together in a truly collaborative system with an understanding that we are physicians, when things really go wrong, they like us to be there. And I think that's very important. I think that we should take a lot more charge as perioperative physicians. And this is extremely difficult. One of my bailiwicks right now is to try and decrease the amount of preoperative testing that we're doing. You know, another healthy, say 50-year-old who might be having a knee replaced or even a hip replaced, I mean, if they've got their knee damaged because they're running marathons all the time, they don't need a nuclear stress test.
Right.
For $2,300. We don't need all that. It's not going to change the anesthetic. I mean, I feel that something like, less than probably 0.2% of the tests we do actually impact our anesthetic or surgical management. And we're spending something, $60 billion a year on unnecessary testing.
Why do you think we're doing these many tests?
Oh, because it's a bit of a back-scratching situation. I think that internists depend on surgeons for referrals back for all sorts of testing. I think that hospitals do a lot of unnecessary testing because it keeps the labs in business. I think radiologists, cardiologists can read normal tests. And I think it's just such a complicated system. So many people involved, so much money involved.
What do you think about this improvement in technology that we see happening around us? These anesthesia information management systems, the electronic health records, if you will. They're touted to improve patient safety. There's clinical decision support in them. They're built into them. They have lots of alerts when the wrong drug is being given. They help with skip protocol adoption. Do you think that the future is bright for that technology?
Oh, absolutely.
Are you excited about it?
I wouldn't want to spend a day without having our AIM system. We've had it at Sinai since 1990, something or other, something like that. And what I think is that in future, you've got these AIM systems. You don't have to hand out pens at these meetings anymore.
Thank you.
And yet, I've been involved with the electronic health record industry for quite a number of years, and as I understand it, the adoption of AIMS is many years behind the adoption of health information technology in non-anesthesia areas. Do you have an explanation of why or how rapidly it will be increasing?
Well, we've been working with this system right now at Sinai. Now, I can get as much information out of it as other physicians put into it. Now, if the Chinese doctor down in Chinatown or the Russian doctor in Brooklyn does an input into the machine, I can't get this information back out again. And I say to the Russian, or I say more to the Chinese individual, what operation are you going to have? Look blankly at me. What's the name of your doctor? What medications are you on? Oh, and they bring me a great big bag of Walmart, all written in Chinese. This isn't too helpful. So I've got to get the input from these peripheral doctors. And many of them say it's too much money. They're not going to put that system into their office yet.
But what we've been hearing from a lot of AIMS vendors and anesthesiologists, and I think you'll agree with this, is that anesthesiologists have tended to resist bringing the automated anesthesia record into their hospitals and in the community setting for fear of increased liability, all the kinds of things that when these physicians were used to writing their anesthesia records on their own, and now all of a sudden a computer is doing that for them.
Well, this obviously is fallacious. For years we did railroad tracks, anesthetic records.
Right.
It is now increasingly evident that if a patient does not exhibit variation in blood pressure and pulse rate during the procedure, there is something wrong with them. They are not responding the way they should. And in fact, the patient who has steady state blood pressure, pulse, is in trouble. And they're not being as responsive to accommodate, their body is not able to, cardiovascular system cannot accommodate to the changes that are caused by the various drugs and maneuvers and stress response. So what we get out of the automated record keeper is we see really what is happening. They have analyzed quite a few medical legal cases right now, and they find that in something like 70 or 80% of the cases, having automated record keeping actually helped the anesthesiologist. Sure, if you've got no end-tidal CO2 after intubation and you do nothing about it, you're liable.
Right.
If you have a pulse oximeter going down to 50% and you've done nothing about it, and this is all recorded, you are liable. But for the most part, there's no doubt in my mind that the automated information management systems are excellent. We should have them, everybody should have them, and they're here to stay.
Do you think it improves workflow? Because that's always been one of the fears, and the resistance to it has been that I don't want my workflow interrupted by having to learn and work with a system that might actually slow me down.
Well, if you put in your own template to start with, what sort of anesthetic do you want to give in this case? Half your work's already done for you. And the wonderful thing is it's legible afterwards. The number of anesthetic records I've looked at from a medical legal point of view, they're just not legible. The other thing is they are definitely helpful for the SKIP project, because we have a little button on our machine that says, have you given the antibiotics appropriately? Until you push that button, you can't move on to the next page. So that helps you. Does this patient have appropriate beta blockade? the statins being given? What's the temperature looking like? It gives us all the buttons to remind us of all the SCIP projects and all the other things that we have to do.
And you work with young residents. How do they feel about it? For them, I would assume it's fairly normal because they're starting their training with this. It's just part of the way it is.
They've got everything, and they've got their phones. And if they didn't have this, I don't know. They couldn't function without of this. They couldn't function with a pen and a paper record anymore.
Dr. Frost, I cannot tell you what an honor it is to sit here
Thank
with you and speak with you. If somebody told me during my residency that someday I'd be doing this, I would have said that's only a dream. Thank you.
Thank you.
Thank you very, very much. This is Dr. Howard Rollins and Dr. Eric Fishman with EHR TV. We've been speaking to Dr. and Professor Elizabeth Frost at the New York State Society of Anesthesiologists, PGA 2011. Thank you.